what's up, everybody? How you doing? George Crawford. But I guess y'all don't know me, so I'm competent. That's pretty much the sum up of it. Just a couple things about me, disclosures. Um, Ethicon Endosurgical. I teach other surgeons how to operate. Modern surgical design. I have one patent granted and two pending, and I'm on Instagram. You can probably find me at Surgery MD. That's the interesting stuff. But there are a couple of other ones. The other one I would really go to is called Today in Surgery. That one is where a lot of the pathology that I do on a day-to-day basis is posted not only for patients but for other healthcare people to look at. So it's pretty much just down and dirty pathology stuff. The Surgery MD one is the fun account. Today we're going to talk about breast disease. Before we do that, kind of go over the anatomy of the breast. There are, of course, the breast, nipple, the areolar complex. All of that is what we all know about. But there are a couple other things like the pectoralis major muscle. That is what the breast sits on. You also have to look at it as a border of the axilla, axillary lymph nodes. Inframammary fold is another border. The sternum is another border as well. So these will come to play somewhere down the line when we start talking about surgery, especially for mastectomy. With regards to other diseases, fibrocystic disease, stuff like that, we're also going to talk about the ducts, lobules, mammary glands, all that stuff comes into place. But like I said, we'll move on from that. With regards to taking care of breast cancer or breast disease patients, all of this starts with a history and physical. You kind of got to go over, figure out what the risk factors are, family history, all that good stuff, and then physical exam. Physical exam can be broken up into two different types. You're either looking at what I like to call magic fingers or circles. These are the basis of almost all breast cancer examinations. Not just paying attention to the breast, you also have to look at the axilla to see if you feel any lymphadenopathy. This can be important when you're talking about cancer. It can also be important when you're talking about fibroadenomas versus maybe an abscess. So physical exam is really important in breast because it kind of gives you a base to start your diagnosis. So you need to do that. The other thing to look at is mammogram, ultrasound, or any other tests that come with it. When we're talking about mammograms of breast cancer or the diagnosis of whether someone has breast cancer or not, then you go into what's called a BI-RADS rating. That is basically the way that the radiologist tells the physician what they are thinking about when they look at the mammogram. It goes 1, 2, 3, 4, 5, 6. 0 means they don't know what they're doing and they need more additional tests. Number 1 means it's normal. 2 means there are findings on it, but those findings are considered within reason for a woman of that age and risk factors or whatever. 3 means they don't know. It's halfway between 2 and 4. When it's halfway between 2 and 4, you have to do a short follow-up. You usually do a mammogram once a year. The true recommendation is 50. Some people start at 40. Some people start at 35. But the true recommendation for a mammogram is at 50. But you do it once every year. If you get a BI-RADS 3, what you do is do a 6-month follow-up for 2 years. So 6 months, 6 months, 6 months, 6 months. In that time, they either have to be downgraded from a 3 to a 2, which means you go back to their original date, or excuse me, you do upgrade them to a 4. If they're upgraded to a 4, then that means they need a biopsy. We've recently broken down the 4 into A, B, and C. But realistically, it doesn't change anything because at BI-RADS 4, you need to get a biopsy. BI-RADS 5 means it's basically suggestive of cancer, and you got to prove that it's cancer by any means necessary. What that also means is that this patient more than likely has some of the findings that we talk about when we are looking at mammograms. So spiculation, taller than wider, and all that other stuff they'll go over in radiology. But when you have those findings on mammogram and or ultrasound, that's when you give someone a 5. 6 means that the patient has breast cancer. It has been proven that they have breast cancer, but for whatever reason, we haven't done anything about it. And that can be for a host of reasons. Patient's palliative care, patient is something else going on that makes taking care of her a risk, him or her a risk. So keep in mind, every once in a while you will see a BI-RADS 6. Now, with regards to mammograms, what you have to do is look at it and say, okay, how do I read a mammogram? Now, the simple way to read it is, first, this is a normal mammogram. You can see the chest wall on the RMLO version versus the CC version. You don't see the chest wall. Now, RMLO stands for right medial lateral. So if you put your head between two breasts and look outwards, so you look to the right breast and you're looking from medial to lateral, that's this view. The other one is craniocaudal. So it's basically looking straight down at the breast if they're on you. The little marker is the nipple marker, so they should almost all have that for orientation. But that's craniocaudal medial lateral. Even though the films are printed out the same way, to read a mammogram correctly, you need to turn the craniocaudal so it looks like this. Now, this same patient on her other side, you can see she has a large white mass, whited out architecture. It looks kind of more tall, maybe, than it is wide, depending on how you look at it. But she has breast cancer. This is a biopsy of a lady's mammogram I did in my office. Oh, I'm sorry, I turned the film the wrong way. There you go. So she has a breast cancer. And you can see it is kind of on the outer upper quadrant of the breast. And that's the main reason that the breast radiologists read upper, outer, inner, is because of these two films and the way that they're read. Now, after you do your physical exam, you kind of figure out what you got to do. So we'll talk about the disease processes from here on out, and we'll kind of talk a little bit about what to do in certain situations, and we'll do some case presentations once we go over the actual lecture. But after you get all this information, you got to figure out what it is you're touching, and that kind of goes with experience, and it also goes with knowing what you're doing. What do you do next? Where do you send them? So all these are questions that you have to be able to answer when you're taking care of a breast patient. No reason to send them to radiology if they've already been to radiology, unless they're getting a stereotactic biopsy and a radiologist is doing it, other than a surgeon. Do you really need to send them to oncology? Well, if you found axillary lymph nodes on your physical exam, then yes, consider oncology first. Do you want to do radiation oncology or medical oncology without a tissue diagnosis? It's a whole different issue. Or send them to a surgeon. Of course, I'm a surgeon, so the answer is going to be send them to the surgeon first. Don't send them to anybody else. To cover breast in a reasonable amount of time, we're going to go split it up into 4 different categories: fibrocystic disease, fibroadenoma, breast abscess, and breast cancer. That's probably the most general way to talk about breast. Fibrocystic disease, 50% of the women, usually younger women, decrease in postmenopausal because they don't have the hormonal effect associated with the breast, so it doesn't increase and decrease in size, so they don't actually have as much pain and tenderness associated with fibrocystic disease. But the majority of the time, it is asymptomatic. So It's often found on a mammogram for an unrelated reason or a screening mammogram. The diagnosis we'll get into later. So when someone comes in with symptoms, they're usually the classic lumpy, bumpy breast, generalized breast pain, sometimes discharge. It's usually not bloody. Bloody discharge is usually a papilloma, but when you biopsy them, they're less likely to be cancer with a bloody discharge than to be something benign like a papilloma. Completely different issue. We're not going to talk about that. That you can go on for days about that. But one of the key things that you notice in breast complaints with fibrocystic disease is the women come in complaining of pain in both breasts. And again, it does associate with their menstrual cycle. Now, as far as someone being truly diagnosed with fibrocystic disease, they have to have a pathological finding of cyst, fibrosis, hyperplasia, or adenosis. The hyperplasia used to be just hyperplasia, but now we go with atypia, without atypia. With atypia is a prelude to probably developing DCIS and needs to be discussed with someone about treatment. Usually we let the medical oncologist do that, but for the rest of this, what I usually tell patients is, hey, you have abnormalities on your mammogram. They came out to be this, but it is not cancer. You truly have fibrocystic disease. What that means is you have disease of your breast, but it's not cancer. So it's important for you to get a mammogram each year, or if you're under 50, every 2 years, so that if something comes up, we can catch it. But outside of that, not much else needs to be done. Again, breast exam, dense mammograms, and ultrasound. If they have a cyst and you want to aspirate it. Aspirating cyst in breast is kind of weird, simply because it's a big cyst. You aspirate it, there's a good chance it's going to come back. If you don't aspirate it, there's a chance that it may go down on its own. Usually what I recommend is if someone has breast pain with a cyst, it's found on ultrasound, I'll aspirate it. If it comes back, I'll aspirate it again. If it comes back a third time, then we have to discuss excising it. Now, anytime somebody has something that's, brown fluid comes out, not a big deal. But if it's bloody, murky, looks a little suspicious, even if it's a cyst, what I will do sometimes is do a true cut biopsy in the office. What I'll do is give me a piece of the cyst wall. Now, the story is cysts are never breast cancer. That's kind of what we tell everybody. Now, the crazy part is I just had a lady that had a cyst that we drained because we thought it was an abscess. It didn't look right, biopsied it, and it turned out to be cancer. So never say never in medicine, but kind of say it. And again, if you have a BI-RADS 4, you need to make sure that you get a breast biopsy. As far as the treatment, again, painful cyst, aspirated, but for the most part, this is symptomatic. So NSAIDs work. Some people use primrose oil to alter something about the hormones. It works. Sometimes it does, sometimes it doesn't. It kind of has grown out of favor. Or birth control pills to modulate someone's cycle. So this is a needle localized breast biopsy. You can see this is the wire that is placed by radiology. We go in and cut out around this. You can see some of this white stuff here and this little purple thing here. There's a little firmness here. I don't think it's cancer. I think it's just abnormal calcifications, but we'll send it off. They'll take a picture of it, tell us if we got the area of concern, and then we'll send it to pathology and have the results in about 5 days. Does anybody have any questions? Just hold them. We'll get to them later. Or write them down. Now, fibroadenoma. So fibroadenoma, think of it as breast tissue, but you are missing something. So some people describe them as breast glands without the associated ducts. I've also seen this described as other ways, but that's the easiest way that makes sense to patients. If you say there's no duct, so it's firm, hard, doesn't really have the ability to drain, it makes sense, and people kind of understand that. Fibroadenomas are non-cancerous. They do not turn into cancerous lesions. They are the most common benign tumor of the breast. Depending on the age, they can increase and decrease in size. If you biopsy something and it comes back a fibroadenoma, 95% of the time plus, it is a fibroadenoma. The reason I say plus is because you have to look at the mammogram. If there are calcifications associated with it, it's one thing. Sometimes women do have breast cancers associated with a fibroadenoma, but they're usually in the same breast but not adjacent to each other. So that's why you kind of have to say it's a non-cancerous lesion. With regard to symptoms, again, it's a marble in a lady's breast. It usually moves around. It's firm, but it has distinct borders that can feel it. It's rubbery. All those are the descriptions for fibroadenomas. Now, the book will tell you they're non-tender. Usually women that come in for fibroadenomas, they come in because of tenderness. So I don't know about that. As far as the treatment options, again, lady comes in, abnormal mammogram. We'll say she's 25. She gets an ultrasound that shows a mass. They send her to you. You get a mammogram first, not because you need it, but because you want to map the breast before you do a biopsy, because a biopsy will mess up the architecture of a mammogram if you do it afterwards. So always have a mammogram before you do surgery on someone. You go in, now you got to decide what to do. You can biopsy usually to confirm a diagnosis and then tell the patient, hey, it's a fibroadenoma, these are almost not cancer. You can take it out or not take it out. Now, some women will say, I don't care what it is, I want to take it out. If it's tender, they want to take it out. If they have a family history of breast cancer, guess what? They want to take it out. So a lot of these we probably take out more fibroadenomas than we do observe them, unless there are women under the age of 21. I will fight and lose patients because I recommend to parents, if your daughter's under age 21, he is more than likely a fibroadenoma. I will get a mammogram and an ultrasound, again, just to make sure, and then tell them nothing else needs to be done. Because what you don't want to do is destroy the breast bud, which is where the breast grows from, so the patient will have a situation where you'll have a lady that has a size D breast on one side and a B on the other. Breasts are not always symmetrical. So I don't expect them to be exactly the same size, but I don't want to alter it too much when they're young, just because everybody's a little anxious. And most of the time, most patients agree and they say, okay, cool, just watch it and don't do anything else about it. Small ones, you can do what's called a repeat true cut biopsy. Some old dude wrote a paper about it, I don't know, a long time ago, but it actually works. You can actually take a biopsy forceps and continually biopsy a fibroadenoma. This allows you to remove a significant chunk of the tissue to where it's no longer an issue. Now, the upside to this is you can kind of do it without surgery. The downside to this is you have to have done a biopsy first. So this is not something you do the first time. You do this once you've confirmed it. There's also a device that came out that does that essentially over and over. It's a mammotome. It's basically a suction device that allows you to remove larger chunks of tissue. As far as the classifications of fibroadenomas, it's very rarely that people classify them because it really doesn't make a difference. It's either fibroadenoma or not. The only time it does is if it's a phylloides tumor. A phylloides tumor is technically a giant fibroadenoma. But the issue with a phylloides tumor is as the cells get really big, they get distorted. And when they get too big, you have a very large mass that has dysplasia in it. And from a pathological standpoint, that makes sense. If you have a large mass, regardless of what it is, you need to get it out because the center is eventually going to turn into something nasty, and that's what a phyllodes tumor is essentially, although it technically is a fibroadenoma. Otherwise, when in doubt, just cut them out. So this nice young lady, she had a mass, and it's kind of hard to feel, but once you feel it, right here, so you can see it's popping between my fingers. So what I'm going to do, make an incision right there, both sides of the mass. Make this incision without cutting my fingers. Kelly. And usually if you spread on both sides of the breast masses, you can usually get them out without any problems. Can I have an Alice, please? Try to make this as small as possible. And that's just breast tissue, that's not the mass. So, it's a slippery little rascal. Mets. So this is the mass. You can see it's white. It's probably going to just be a fibroadenoma. It's kind of firm, but it doesn't have an appearance that looks like malignancy. So yeah, that's what it looks like. We'll send it off. Questions? Fibroadenoma. All right, cool. Hold them. The next stuff is breast cancer. Okay, so breast cancer is second leading cause of cancer deaths in women. It is the second leading cause of cancer in women behind skin cancers. Now, we'll get into the political aspect of breast cancer, which is a good thing and a challenging thing at the same time. Perfect start out is the risk. If you look at every breast cancer website or anybody that has a financial gain in breast cancer disease, they quote the risk of developing breast cancer as 1 in 8. Now, that 1 in 8 is true if you live to about 108 years old. So what they do is they basically extract and say, no matter who you are, no matter how old you are, what is your lifetime risk of developing breast cancer? And yes, it is 1 in 8. Before, there was a financial incentive in it and a treatment incentive in it. We used to do to the life expectancy. So the average life expectancy was 76. It's moved up to 78 in women. That's 1 in 11. Now, 1 in 8 versus 1 in 11 doesn't sound like a big difference, but if you say anything is 1 in 8, it sounds like it's really bad versus greater than 1 in 10, not as bad. Breast cancer is bad, there's no question. But again, Susan B. Comer's foundation is actually a real interesting story. If you get a chance to read about it, it's pretty cool. But breast cancer has probably the largest budget of any disease that we treat. But it affects a lot of people. So it's a little different. In 2020, there will probably be 250,000 breast cancer diagnoses in the United States. So it's a real big number. So yes, there is a need for the machine that goes behind it. If you look at the statistics from 1986 to 2011, more people survive breast cancer now than they did before. It's almost a 40% reduction, and that reduction plus increase in early diagnosis is primarily due to the Susan B. Comer Foundation. So good stuff, bad stuff. We'll talk about the bad stuff later. Well, maybe not. I don't know. Depends on how much time we have. Susan G. Comer. So, men, don't forget about it. 1 in 900. I've treated 2 patients in my lifetime with breast cancer that were men. Treatment's still the same. Doesn't change much. Hormonal therapy is a little different, though. As far as Alabama, not a good statistic. Estimated in 2020, 28,000. So that is essentially 10% of the breast cancers that will be diagnosed in the United States will be diagnosed in Alabama. And our death rate probably 10,000 is about the same as about 10%. So it's a real disease, especially if you're staying in Alabama. You got to think about breast cancer. As far as a overall global view of breast cancer, I'm not doing that here. We could spend weeks, months on breast cancer. They have fellowships on breast cancer. If you add in medical oncology, radiation oncology, they have breast cancer fellowships. So realistically, y'all got 13 slides, maybe 20 minutes. So this is an overview. We will talk about treatments a little bit when we get to the question and answer part of this presentation. Now, before 50, after 50, if you are over the age of 50, common things being common, your breast cancer will present as a palpable mass. Because it will present as a palpable mass, a self-breast examination is, over the age of 50, it will present with calcifications or a palpable mass. So if you're over the age of 50, that's why you do mammograms, because they will present with calcifications, turn out to be DCIS or breast cancer, and then you'll do treatment. If you are under the age of 50, so you are 49 and below, they are more likely to present as a palpable mass. So because they will present as a palpable mass under the age of 50, the recommendation to do a mammogram every year is controversial. If you start with cancers, any cancer, say, okay, diagnosed, average age is 50 years old. We always go 10 years before that to start screening, because malignant transformation from 0 to 100 is not that real quick. It's not real quick. It takes about 10 years. So the gynecologist or primary doctor say, okay, we're going to start screenings at 40. So everybody's like, okay, cool, let's do that. Now, 35 is usually the mean age if you're going to get a breast cancer in somebody, not early, but you'll see this peak around 30 to 35, maybe 45. So what happens is some of the gynecologists and in their societies, they say, hey, we're going to start doing them at 35. Now, if you are a breast surgeon, some of the oncologists, we will say the problem with that is if somebody lives to be 78 and you're getting a mammogram every year from the age of 35 to 78, common things being common, you are more likely to cause a cancer given the amount of radiation that you're giving them every year for that long than you are to pick up a cancer that wasn't going to be found anyway. Now, the people who have a political stake in breast cancer say, well, wait a minute, we don't want one person to die of breast cancer. That's true. We don't want anybody to die of breast cancer. But if we are potentially causing 5 breast cancers or 5 cancers that, but even though they're not breast cancers, down the line, to maybe pick up that 1 in 1,000 patient that has a breast cancer that's not palpable under the age of 50, from a medical standpoint, that's kind of questionable. But again, there's this political arm of breast cancer, which does benefit, but this is kind of one of those touchy things. They did a study, somebody presented an article, it was probably like 4 or 5 years ago, where Medicare and the government said, yeah, the data's clear, you don't need to get mammograms at 50, and everybody went up in arms. And they said they crucified the dude that did the research, but his research was sound and solid. And medicine, the medical community was kind of like, yeah, dude is right. So what has transpired now is we've kind of gotten rid of a lot of practices doing mammograms starting at 35. If a woman comes in with a breast mass or a family history of breast cancer and they want a mammogram, your gynecologist will order it. If we're doing surgery on someone or somebody has a mass, we'll get a mammogram. But after that, after it's all done, let's say you have a 35-year-old that comes in with breast cancer, or comes in with a breast cancer concern, she has a fibroadenoma, no evidence of cancer, everything's fine. What we usually do now is say you can have a mammogram every 1 to 2 years. And they'll usually ask you, what do you think is better? And if they're under the age of 50, I say do it once every 2 years, do your self-breast examinations, and if you find something, come in and we'll get it done. Get it biopsy. But that's my 2 cents. You can find people on the other side of the coin. It's fine. As far as the risk factors for breast cancer, there are a lot of them. They all kind of make sense once you start thinking about them. Of course, female, more likely in female than male, 1 in 11 versus 1 in 900. The older you are, the more likely you are to have a problem. DCIS, LCIS, hyperplasia with atypia puts you at a higher risk. So if you had a biopsy that was positive, as well as a previous history of breast cancer or a true family history of breast cancer. What that means is a first-degree relative. So if your grandmama had breast cancer and your mama didn't, that does not count. If your mama had breast cancer at the age of 80, it doesn't count. Usually. So just kind of watch the family history of it. Usually I don't debate that with patients that come in. I'll just positive family history and dictate exactly what I'll ask them which relative was, and then I will dictate which relative it was in my note. BRCA1, 2, which means that a family member that had a breast cancer at a young age, somebody decided to biopsy and look for the BRCA1 gene, came positive, different issue. They're at a significant risk of developing breast cancer, and you need to treat them a little differently. If they've had long-standing exposure to radiation, obesity, early periods, late menopause. The early period, late menopause is basically due to prolonged exposure to estrogen. So those patients are at a higher risk of developing breast cancer. Childbirth. If you have a child at 30, think of it as childbirth breaks up your hormonal exposure of your breast to breast cancer. So if you can get a break in your 20s, that's great. If you have to wait till your 50s, again, that's a long stretch of breast exposure to hormones. So you're at a little higher risk. Never being pregnant before again, and you don't have that breakup in your hormones because of the baby. Not suggesting everybody go out and get pregnant, but it does help as far as preventing breast cancer. Postmenopause hormone, same thing, and alcohol. As far as looking at symptoms when it comes to breast cancer, The one thing that everyone will say is that there was a change in the way that my breast looked, feels, something wasn't right. That is probably the most common thing, and when someone says that, take it seriously and start investigating. This can be anything from change in the way that the nipple is retracted or not. It can be this crusting around the nipple. It can be different changes in color. You can be a lump that's not there before. You can have dimpling in the skin, host of things. But if someone has any changes, take a look. As far as diagnosis, it starts with the breast exam. So again, you got to look, see what you're dealing with, because you have to decide whether the patient has a breast cancer or a breast abscess or mastitis. So you need to have an idea in your mind what you're dealing with by doing the physical exam. Now, after that, mammogram is a gold standard. Sometimes they won't be able to see enough information, so they will add an ultrasound as a second study, although I use it as a first study if the women are young. And the new thing, or not new, it's probably been going on 4 or 5 years, are MRIs. MRIs give you a whole lot of information about breast disease. The problem is that unless you have dense breast tissue, a MRI doesn't really change what you do except for certain situations. So if you have somebody with lobular carcinoma or dense breast that gets a biopsy, because there's a chance that you can have a synchronous cancer on the other side, a MRI is a good way to figure that out. The problem with the MRI is it's hell of expensive. If you look at the data of an MRI from a insurance standpoint, the amount of money they pay for the MRI relative to the amount of change that occurs in someone's treatment plan, it's not worth it. Usually, the outcome of an MRI for breast is that they end up finding every little nook and cranny, and they want biopsies, want to change this, they want to do this, and most of that stuff is benign, and then they come back with, okay, let's continue the same plan that we had before. So it provides oncologists with a lot of information that may or may not be necessary. Not saying they're a bad idea, just kind of have to think about it before you order one. Now, once you have imaging, you then got a biopsy. Now, we used to take everybody to the operating room to do breast cancer biopsies. What we now do is try to biopsy everybody in the office or in radiology specials or something like that before we take them to the operating room. Think of it as this way. If you have a lady who comes in with a breast mass, take her straight to the operating room, take out a mass, you get a breast cancer. You then got to bring her back to the operating room, do another operation, and do a axillary node dissection or sentinel lymph node biopsy. So she's had 2 procedures versus if you're in the office, it's palpable, stick a needle in it, comes back a breast cancer. You then say, okay, you now have breast cancer, we can do 1 operation. So it saves the patient trips to the operating room. And also, if it's a big mass and it's seen like 5 centimeters on mammogram or ultrasound, or you do an FNA of the axillary and lymph nodes in the office, then you have the potential, the ability to treat that patient with preoperative chemotherapy and radiation prior to going to surgery. It may be the difference between someone going from a lumpectomy, from a mastectomy to a lumpectomy. So try and biopsy everybody before you take them to the operating room. Now, that's not always possible. Some women, if they have very large breasts, very posterior calcifications, if they have implants. There are certain situations where a biopsy is not ideal, but you have to tell these patients, hey, it is what it is, and they usually understand. Now, as far as getting that biopsy, you have a couple of different options. You can do fine needle aspiration, which is like usually a 23 gauge needle, true cut biopsy, which is a little bigger needle, which is usually my preferred go-to in the office. Mammotome, which you talked about, ultrasound guided biopsy in radiology or in the office, while you leave a clip to identify the area that you biopsied, or the stereotactic biopsy, which is basically biopsying the breast under mammogram guidance in the radiology suite. As far as breast cancers, I'm going to give you DCIS. It's ductal carcinoma in situ, but it's a little different than regular breast cancer, because if you treat DCIS with lumpectomy and radiation versus mastectomy, just those two treatments alone, it is 95% successful in treating the disease. Now, that other 5% is where it gets tricky. Usually the 5% is not because it's DCIS, it's because there was a breast cancer there that was missed. So, now if you move forward about 10 years, we've kind of gone through this thing where we now have low-grade DCIS, intermediate-grade DCIS, or high-grade DCIS. With high-grade DCIS, they're recommending that you do a mastectomy over a lumpectomy because of the recurrence. If you have palpable DCIS, they recommend that you do a sentinel lymph node biopsy, because palpable DCIS may signify that the patient has a breast cancer associated with the DCIS, and if you remove the mass, you can't do a sentinel lymph node biopsy, and you have to do axillary node dissection, which puts the patient at risk for lymphedema. And some people are still doing lymph nodes on DCIS as well. Now remember, we're talking about a disease that if you do it the same way we've been doing it for the last 20, 30 years, the survival rate is 95%. So most people would agree that doing that is probably extra, but when the oncologist decided to move DCIS out of its own group into cancers, it fits a little better in their treatment regimen, but again, you're probably over-treating a disease that you don't have to. But now we get tumor markers, ERP are positive. The oncologists are pushing for lymph nodes. So again, political thing is pushing, but again, you may be doing more harm than good. Now, if you look at all things of the breast that are bad overall, we'll go with breast cancers are usually 55% of the disease cases versus DCIS is about 25%. Invasive lobular is about 5 to 10%. We don't do that mirrored biopsy thing anymore with invasive lobular carcinoma. The recommendation now is actually to get an MRI, which is kind of interesting. Phylloides tumors, which you talked about, and then mucinous medullary papillary metaplastic. These are all these weird breast cancers that, for the most part, are treated the same way, with the exception of inflammatory breast cancer. Now, inflammatory breast cancer is its own entity. The easiest way to think of inflammatory breast cancer is it is infiltrating ductal carcinoma that is spread locally to the skin first. Now, because the skin is technically a separate organ than the breast, it is considered locally advanced or metastatic disease. So those patients get preoperative chemotherapy, radiation, followed by mastectomy. So it's treated the same way if you had a large infiltrating ductal carcinoma. From a surgical standpoint, there are really not that many options. You either do a lumpectomy, which is removing the breast cancer or breast mass and the surrounding tissues, but leave the breast intact, the majority of the breast intact. Whether or not you're supposed to leave the nipple or not is a little controversial. Sometimes we do have to remove the nipple, but for the most part, you try to leave the nipple when you're doing a lumpectomy if possible. versus a mastectomy where you remove the entire breast. Now, the biggest difference, lumpectomy versus mastectomy, is if you do a lumpectomy, it is considered breast conservative therapy, so no reconstruction is required, but because you're leaving normal breast tissue behind, you have to treat the remaining breast tissue with something, so that is usually radiation. Mastectomy, you don't need radiation unless your axillary lymph nodes are positive. Now, sentinel lymph nodes, we used to do it with either dissecting and looking for a lymph node that was palpable, or and when we did that, we would use methylene blue or lymphozurin blue. Then the other option was to do a radioisotope, a radiotracer, and use a neoprobe to find out where the tracer went. So we did this for probably 2000, 2005. All that data, kind of looked at it and realized that if you do the radiotracer or a dye, you're about 75 to 80% effective in finding a sentinel lymph node. If you combine them, you end up about 95% effective. So right now, the standard of care is to do a radioisotope and use a neoprobe at the same time of injecting methylene blue, either around the breast cancer or in all four quadrants of around the nipple, massaging for 5 minutes, and then looking for the lymph node. We used to think there was one sentinel lymph node. Now they want you to remove at least 2 to 3 lymph nodes at the same time. If you have a lymph node that is positive, and again, this is where we get into a controversy, you then have to do an axillary node dissection. The standard of care right now is if you have a positive lymph node, then you do an axillary node dissection. Now, again, this is for staging purposes, less for treatment. So it's not like if you have one positive lymph node and you do level 1, level 2, level 3, and you get 30 lymph nodes, that's better than just getting the 10 that you need. It doesn't work that way. It's not less is more. I mean, more is less. More is better. There was a study that went out probably maybe 10 years ago that looked at the current trends in the way that medical oncologists treat positive lymph nodes. What they essentially said is, if I have somebody with 2 positive lymph nodes, I'm treating them with radiation. Whether you give them 1, 2, or 8 lymph nodes, I'm still treating them with radiation. So there is a subgroup of surgical oncologists that focus on breast, that if a woman has 2 positive lymph nodes, they don't even do an axillary node dissection. They just say they're going to get treated with radiation and they'll be fine. Is that the right answer? So if you tease out the data, yes, that is probably the right answer. But you have to have a good grip on that data to defend that, especially when the majority of women are getting axillary node dissections if they have positive lymph nodes. I don't do that. I think that if you have a group of oncologists at your facility that agree with that treatment option, that's fine. The issue is if you have one oncologist that says they will treat and the other one says they need axillary node dissection, depending on who that patient sees, you get mixed signals. So I just keep it standard, and if they have a positive lymph node, I do an axillary node dissection. But I do get level 1 and level 2 lymph nodes. And you go over this in surgery about the borders, axilla, long thoracic, thoracodorsal vein. Thoracodorsal nerve, long thoracic nerve, and the axillary vein. The easiest way to think about it is level 1, level 2, level 3. Level 1 are the superficials. Level 2 are up to the deep border of the pectoralis major muscle. Anything underneath that muscle is a level 3. You only need level 1 and level 2 lymph nodes. If you have a level 2 lymph node that is positive, 90% of the time you're going to have a level 3 lymph node that's positive, and they're going to get treated with radiation anyway, and you can't really get those nodes. If you do, you're increased significantly the risk of lymphedema, which is debilitating and Up until recently, there haven't been any real good surgery options to treat it. There are better options now, but they're not amazing. Outside of surgery, there are some non-surgical treatment options. And again, radiation, chemotherapy, hormone therapy, ERPR positive versus targeted therapy, HER2 new positive patients, and immune therapy in patients that you can't do hormone therapy or targeted therapy, using the body's own immune system to attack the specific cells is interesting. Another option is palliative care. Sometimes patients come in with a biopsy, do a local excision, and that's it. So palliative care for breast cancer is an option. So this patient unfortunately has a diagnosis of breast cancer. You can see the mass here on the side and over here. Kind of has a hard, firm appearance to it. My finger's over the nipple. Once you flip the specimen over on the back, this is where it's attached to the chest wall. You can see there's a hard mass here as well. When you look at it from the sides, you can see it. This is what breast cancer looks like after a breast has been removed. This is called a mastectomy specimen, which means we remove the entire breast. So we did the left side already. We're now doing the right side. She had a previous lumpectomy. We attempted to do a stereotactic. It came back questionable, so we ended up having to do surgery. So this is her previous surgery site. So we've got to incorporate that into this incision to remove all of this. So her incision is going to be different from that side. Because it's a breast cancer, we've already injected her with a radioisotope. So what we have to do now is inject about a cc total of methylene blue in 4 quadrants. We do that so that we can then massage the breast and identify the sentinel lymph node. So this is the first part of doing a sentinel lymph node biopsy. And I don't do an injection around the tumor. I believe that a circumareolar injection is just as effective, especially if you incorporate it with a radioisotope. So once we get that 1 cc of methylene blue injected, we then massage it for 5 minutes, and then and then we'll use a needle probe to look and find it. In her, I'm doing a little backwards. I'm actually going to remove the breast and this area, and then go into the axilla through this incision, as opposed to making a separate incision. So normally she would have an incision here and here for the breast, especially if we're doing a lumpectomy, but in this situation I'll do it all through this same incision. So it'll save her just a little bit of pain. This is the axillary node content. This is the sentinel lymph node, or the lymph node that determines where the actual cancer, whether or not it's gotten into the lymph node. This young lady unfortunately had a positive lymph node. Because of that, we had to remove the rest of the axillary content. So this is when someone does an axillary node dissection. All of this tissue is what is removed. This has approximately 10 lymph nodes in it, plus this one makes 11. A level 3 lymph node is one that's a little higher. We found this one, and it was also found to be positive. If you look close, you can see there is some blue dye in it as well that is injected at the beginning. Okay, that was a lot. Questions? All right, moving on. Breast abscess. Breast abscess is kind of a weird topic. It kind of falls into the mastitis group versus not really mastitis versus breast abscess. It's kind of like a square is not a rectangle, but a rectangle is not a square. If you have somebody come in with mastitis, they may be developing into a breast abscess, and you're just seeing it early. So keep that in the back of your mind, and that's kind of why I grouped them together. A breast abscess is treated a little different than a regular abscess anywhere else in the body. Now, part of that is because of where it is. Part of it is also where it is. Risk for breast abscesses, pregnancy, bites, whether it's dogs, cats, or babies, or humans, nipple piercings, usually caused by Staph aureus. These abscesses can be superficial and seen in the skin, and you can wipe them off when they rupture, or they can be very deep. Some of the largest abscesses I've drained have been in lactating women. So that's why it's important to treat mastitis early so they don't develop into a breast abscess. I personally have treated more patients with breast abscesses from nipple piercings that were removed and replaced than I have any other entity. To the point where if I have a woman that I'm doing a gallbladder surgery on or something else and she has nipple piercings, I tell her do not take them out, despite what they will tell you in radiology. What they tell you preoperatively that those do not need to come out, because as long as I know they're there and I'm not around the nipple ring with the bovie, you'll be fine. It's not going to jump because there's metal touching. That's not real stuff. Lactating women understand that there's certain things that put you at risk. Basically, if you have a breast full of bacterial nutrients and you have a pseudo one-way valve with your breast, if you don't breastfeed on a regular schedule or you let that become stagnant, milk becomes old, it's nice, got plenty of nutrients, dark space for bacteria, and you're at risk. So just remember that when you're lactating. As far as other risks, childbearing age, obesity, history of a previous breast abscess, inflammatory breast cancer, again, kind of, sort of, but not really, and smoking. Don't smoke. As far as the diagnosis, it is usually a clinical diagnosis. Some people will get mammograms. The mammograms are always read as BioRADS4, and it complicates it because it's a breast abscess, not really a mass. So trying to biopsy it is a little awkward. But if you have a breast abscess that looks weird or you're concerned about it, yes, biopsy it at the same time you're draining it. Ultrasound can be useful, especially in the treatment of breast abscesses, because treatment is first antibiotics. If the antibiotics don't resolve the mastitis, then some people recommend hot compresses around the abscess to help drain it through the nipple complex. If that doesn't work, this is where it gets different from regular abscesses. So you aspirate a breast abscess before you drain it. The main reason you do that is if you can decrease the bacterial load, there is a chance that the breast will help resolve this. So I usually give it one shot. I think that they need to put a size. This needs to be reworked a little bit. If you have a big breast abscess, just drain it. There's no reason to do aspiration. If it's a small one, superficial, or you see like a 1 to 2 centimeter thing, yes, you can aspirate it, put them on antibiotics, and they should treat. But most women, when they come in with a breast abscess, it is big and needs to be drained. As far as draining it, I typically use the same 2/3 rule that I use with abscesses, which is I'll feel the abscess, see how big it is, and make my incision 2/3 the size of that abscess. So the length of it or the width, however you want to measure it, but the largest length or width, I make the incision 2/3, except on the face or someplace that is cosmetically sensitive. But for the most part, that's how I drain all abscesses. And again, if it's weird, biopsy it. Now, other treatment things. One is if somebody has a recurrent breast abscess. So they had a breast abscess, treated it, came back, treated it, came back, treated it, came back. What you need to consider is completely excising that area. If you completely excise that area, then more than likely it will decrease the chance of it recurring. Breast abscesses can either be very easy to treat, pop them, move on, antibiotics, move on, or recurrent abscesses or large abscesses requiring dressing changes, which is just horrendous on the breast to leave it open and do breast dressing changes. But you have to sometimes. It is what it is. Especially if it's in a lactating woman when she's breastfeeding and then is now can only use one because her mastitis turned into an abscess. It had to be drained. So it does complicate stuff, and it's a little trickier than treating a regular breast abscess. And always remember, no matter what you're doing, if your breast abscess looks weird, there is a chance that it is cancer and you need to do a biopsy. Again, follow up after it's treated, 1 week, 2 weeks, make sure it's completely resolved, get a repeat exam, and then consider biopsying. If it just in the back of your mind said, I just want to get a biopsy, then get one. This nice young lady presented postpartum with a breast that would not drain. We subsequently aspirated a large amount of old milk from her breast, and the fluid recurred. Therefore, we took her to the operating room to drain this large breast abscess. Here we are getting all of the old milk and pus out. We are also breaking up the loculations on the inside so that we can get all of the pus drained. We ended up removing about 500 cc's of pus from her breast. And that's pretty much breast abscesses / mastitis. Does anybody have any questions? All right, cool, guys. Hope y'all enjoyed it. See you later.